Thank you for joining us for this Learn from the Experts webinar titled ICD Shock Reduction, Update on Economic Impact and Therapeutic Options, brought to you by the Heart Rhythm Society and the American College of Cardiology Foundation. Our moderator is Dr. Thomas F. Deering, Chief, Piedmont Heart Institute Arrhythmia Center, and the Mark E. Silverman Educational Chair, Piedmont Heart Institute. Please note the disclosure policy of the American College of Cardiology and the Heart Rhythm Society and the disclosures of our presenters. Please note the disclaimer. This program is made possible in part by a grant from Medtronic. And now I'm pleased to hand the program over to our moderator, Dr. Deering.
Thank you very much, Kurt. Pleased to be here. We have a very hopefully beneficial webinar for our audience here tonight. We all know that ICD therapy has had a significant positive impact on reducing mortality among patients with systolic left ventricular dysfunction by, as needed, delivering necessary shocks. But we know that not all shocks that are delivered are beneficial or appropriate or even are necessary. There are inappropriate shocks that derive from non-rhythm-related issues, such as oversensing either intrinsic cardiac signals or extrinsic non-cardiac signals, as well as inappropriate shocks from device or lead failures. Tonight we're going to be focusing upon inappropriate shocks that may derive from rhythm issues such as supraventricular tachycardias, of which atrial fibrillation and atrial flutter are probably the most common, although sinus tachycardia can be as well, and probably unnecessary shocks that can derive from ventricular tachycardia that could be self-terminating before shock is delivered, or ventricular tachycardia that might be terminated by anti-tachycardia pacing. And obviously the implications of these shocks are significant, with psychological, physical, morbidity, and mortality factors associated with them, as well as, in addition, utilization of significant healthcare resources. So fortunately for this webinar, we're pleased to have two very significant expert faculty attend with us. We have, first of all, Dr. Mintu Tarakia, who is an assistant professor of medicine and health research and policy at Stanford University, where he is also the director of cardiac electrophysiology at the Veterans Administration System at Palo Alto. He is also an associate investigator for the Center for Healthcare Evaluation. In addition, we have Dr. Bruce Wilkoff, who is a former president of the Heart Rhythm Society and is the director of cardiac pacing and tachyarrhythmia devices at the Cleveland Clinic. He is a professor of medicine at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University. So with those introductions, I would like us to get started, and I'll hand the baton over to you, Mintu, to get us going, addressing the issues of healthcare resources and utilization associated with ICD shocks.
Tom, thank you very much for that very kind introduction. It's a real pleasure to participate in this webinar. I'm going to talk about the economics of shocks and describe the utilization and expenditures associated with shocks. Now, I do want to state that some of the research, as a disclosure, that is being presented is from research that was sponsored by Medtronic. So what we do know is that ICD follow-up care is a major cost driver. And if you look at the annual cost of care based on several randomized trials, SIDS, MADID, and AVID, the total cost of care per year after implant range from $5,000 to $17,000. If you look at observational data from Medicare or from Kaiser, those costs are tilted slightly upward at $10,000 to $17,000. And from this data, given the longevity of patients who have ICDs primarily in a primary prevention situation, the follow-up costs actually exceed the initial implant costs. And although ICDs have repeatedly been shown to be cost-effective, in fact, the variation of this follow-up cost can significantly alter the cost-effectiveness profile of ICDs. At the same time, we also know that there are a high burden of shocks in trials and in the real world. And what this graph shows are the shock rates through cumulative follow-up in MADID2, DEFINIT, and SCUT-HEFT. in which we can see that the shock rates for inappropriate shocks ranges from 12 to 21%, and for appropriate therapies from 14 to 18%. Now, if you look at observational data from the altitude registry, you can see that the shock rates for inappropriate shocks is about 20% and appropriate shocks for 15%. So all in, the risk is 12 to 20% over this period. We also know, and we'll hear more about this from Dr. Wilkoff, that there's a really clear relationship to mortality defined, not just for inappropriate shocks, but of course even paradoxically for appropriate shocks. So the question then is, what about cost and resource utilization, even if these shocks may be, quote, appropriate? Now, this matters for many reasons, and one way to think about this is the relationship of actually receiving shocks to quality of care, and then the relationship of that quality to outcomes. So currently, ICD shocks are not a proposed Medicare quality measure, but we do know that the Affordable Care Act has implemented bundling demonstrations, and these are bundled payments for episodes of care for 30 to 90 days post-ICD implant. There are currently 167 hospitals participating. We also know that there are readmission payment penalties as part of the Affordable Care Act for several cardiovascular conditions, and this very well could expand to include ICD implants. So if, in fact, a link between quality and outcomes is established for shocks, one has to wonder if there may be widespread implementation going forward. We wanted to study this scientifically, and we asked some important research questions, and what we wanted to know is what sort of healthcare utilization does occur after a shock, how much does this cost, does this vary by etiology of shock, and could the patterns of utilization offer insight into the relationship of shocks with mortality? So what we did is we performed a retrospective cohort study using claims and clinical data from remote monitoring data. We took de-identified patients with ICD and CRTD implant data and took remote monitoring records from these patients from the warehouse of one manufacturer. In this case, this was Medtronic. We then linked the data probabilistically, which I'll explain, to health plan records and medical claims from the MarketScan database. And this is a commercially available data set of employee-sponsored healthcare claims. So most of these patients in here are fee-for-service, but it does include information on Medicare supplemental coverage and some Medicaid. We then essentially matched 9,600 patients in creating a matched data set. And the way this was done, again, is we took CRTD and ICD data from a device implant database, which is shown on the left side of the screen here. That data contained, of course, the implant information, shock dates, arrhythmia classification for all of the shock events, and program parameters. We then had claims data from MarketScan, which were de-identified, and these came from 80-plus million patients, and we have demographics, utilization, site of service, claims for the implant made. What we then do is we match this data based on the criteria shown in the middle: implant information, patient location, and site of care. And that yielded 9,600 matched patients. So of those 9,600 matched patients, what we found is that there were 995, about 10% of patients who had almost 2,000 shock events. After excluding a small number of shocks which actually occurred after or during a hospitalization, we were left with 1,873 shock events that we analyzed. And therefore, the unit of observation here are shock events, not patients. And this is what we found. So this graph shows healthcare utilization following a shock event. And the way we define this is we looked at medical claims on the date of shock to 7 days post-shock event based on the shock information we had in the CareLink data set. We considered something shock-related if it matched an ICD-9 diagnosis corresponding to dysrhythmia, syncope, dizziness, device malfunction, palpitations, or tachycardia. So these were very specific for arrhythmia-related signs and symptoms. So using that definition, we can see that 50% of the claims were shock-related, and of those 50%, we saw a distribution where you had about two-thirds in the outpatient category and one-third in the inpatient category. Another way to look at this is that 1 in 3 shock events were associated with related outpatient or ER care without subsequent inpatient care, and 1 in 7 shock events were associated with inpatient care. Now, if we were to broaden that definition from being an arrhythmia-specific diagnosis code to any claims, then the utilization, of course, would be measured at an even higher level. The most common diagnosis-related groups for the inpatient conditions are shown here. First, we know that the mean lengths of stay were not short. On average, they were 3.5 days, but with significant variation. And the most common DRGs that were reimbursed for these shock-related admissions are shown here, and they're basically arrhythmia-related conditions with or without major complications or comorbidities. We then looked at shock-related procedures based on primary procedure or all cardiovascular procedure. And the primary procedure is what's in the primary diagnosis category. And you can see here that the most common situation was that there was actually no primary procedure done as an inpatient. And that was followed by ablation, angiography, and so forth, which is shown there. Now, if you tally all the procedures, regardless of coding position, it's no surprise that ECG, chest X-ray, echo, and an ICD evaluation are the most common. What is also interesting, however, was how many patients received cardiac catheterization and how few patients relative to those received any coronary stenting. So this, again, raises questions about whether there is overutilization of angiography when the stent rate is so low. Now, looking at the outpatient side, we saw that 1 in 3 shock patients had emergency room claims without subsequent admission, and the most common procedures that were done are shown here. And again, ICD evaluation, chest X-ray imaging, ECG were, of course, the most common. If you look at shock-related expenditures, what we found is there was very wide cost variation, and the median cost was $5,700, but look at the interquartile range there of $20,000, so significant variation here. On the inpatient side, I think this is a right-skewed distribution, so it's more fair to look at median cost. It was $8,700, and on the outpatient side, it was $380. So, of course, here, inpatient care is more expensive, and from the procedure data, you can infer that the procedures were the major cost driver here. This slide essentially shows the same information that I previously showed, showing the mean and median cost data for inpatient and outpatient care. So, in summary, 1 in 7 events were associated with hospitalization. 1 in 3 shock events were associated with ER or outpatient care. And there was wide cost variation with the mean and median cost shown here for both of those. So again, inpatient procedures are the major cost driver, and we can see that extensive workups can be triggered by ICD shocks. So there are significant implications here. One is, I think these findings do quantify utilization and identify key drivers of cost. The yield of certain procedures may be questionable, and one has to wonder about the PCI rate relative to the amount of angiography performed. And perhaps strategies to reduce the incidence of ICD shocks may result in significant healthcare savings along with demonstrated mortality reduction. And finally, could healthcare utilization itself that's triggered by the shocks increase risk of death? So, for example, could the therapies downstream of the shock in some way increase the risk of mortality? And could that be one of the reasons that we've seen the observed increases in mortality for inappropriate and appropriate shocks? Again, the limitations are shown here. Our utilization estimates are probably very conservative, and future work will characterize utilization based on appropriate and inappropriate shocks. Thank you.
Bintu, thank you very much. That was a very, very nice presentation demonstrating the significant expenditure that we do see when shocks manifest, and the inpatient-outpatient breakup and the variation, which suggests that there is room for improvement in how these patients are managed. And we will circle back to that in the Q&A session. I would now like to move on to our second and final presentation in this webinar and hand the baton over to Dr. Wilkoff, who will talk about the utilization of certain strategies based on the literature to reduce both appropriate and potentially unnecessary shocks. Bruce?
Thank you, Tom. I want to thank you for this opportunity to talk about one of the issues that I think is most important in electrophysiology. And you notice I'm talking about shock reduction, not inappropriate shock reduction, not appropriate shock reduction, not maybe avoidable shock reduction, because when it comes down to this, it may not make any difference. For our patients, certainly the symptoms that they have are related to having a shock, and if we can avoid the shocks by one of a number of strategies, we may actually make a big improvement in both the quality of life, the duration of life, and certainly, as we were hearing before, maybe health care utilization. So some observations about tachycardias. So this first slide talks about non-sustained ventricular tachycardia versus duration, and this is data taken from empiric and prepare clinical trials. But you see here that there's a lot of non-sustained ventricular tachycardia, but the non-sustained ventricular tachycardia is relatively short. Now, one of the major characteristics of non-sustained ventricular tachycardia is that it's self-terminating. So any therapies that are given for these tachycardias are not necessary because the arrhythmia was going to stop in the first place. So by simply prolonging detection and changing a tachycardia into a treatable tachycardia into a non-event, we can make a big difference in the number of tachycardias that have to go through the SVT versus VT detection algorithms, and also the number of therapies that will be given, both low energy or high energy. Now, if we look at the tachycardias that are sustained, we see here that we've divided the arrhythmias into monomorphic VT and polymorphic VT or VF. And we see this comes from the empiric trial, which looked at two groups of patients, ones that were treated systematically with just by a strategic way of detection called the empiric arm, and a tailored arm, which is where physicians used what they thought was the best for an individual patient. But what you're going to see is that the vast majority of tachycardias that present to a device are not ventricular fibrillation. You could, in fact, not call these defibrillators, but rather cardioverters in most cases. And you see a small percentage of the arrhythmias are polymorphic and requiring a shock, and actually most are potentially amenable to antitachycardia pacing. And you see in green is the not shocked events, and the red the shocked events, and you can see that most of these arrhythmias should be amenable to therapies other than shocks. Now, if we look at the tachycardias as a matter of cycle length, and you see cycle length along the horizontal axis, so the slower tachycardia is to the right and the faster tachycardia is to the left, we'll see that in the two arms, we'll see that most of the arrhythmias are amenable to antitachycardia pacing and not shocking, and even to very fast cycle lengths. So you see here with cycle lengths between 240 and 290 milliseconds, the majority of the arrhythmias are amenable to antitachycardia pacing. And while you can get shocks even with slower tachycardias, it's actually a pretty rare event. And so it's not a matter of cycle length, and this is one of the major findings that occurred from the empiric trial. Now, if you're going to reduce the shocks per patient, you're going to notice that shocks are actually in a small minority of the patients. And so here along the horizontal axis, you see 1 shock, 2 to 4 shocks, 5 to 9 shocks, and more than 10 shocks. And you see that whether they were in the empiric or the tailored arm, that basically most of the shocks occurred in patients that in a very few of the patients. As a matter of fact, 53% of the shocks occurred in 2.6% of the patients, and 72% of the shocks occurred in 5.5% of the patients. So we need to find strategies that are going to reduce shocks in this small subset of patients that will make an impact. So the first trial that really brought these types of strategies into focus was the PREPARE trial, which was not a randomized clinical trial, but had a well-qualified comparison cohort, but tested these strategies. We wanted to avoid detecting slower tachycardias. We wanted to avoid detecting non-sustained tachycardias. we wanted to use SVT discriminators in order to allow for discrimination between SVT and VT, and we wanted to use antitachycardia pacing not just for slow tachycardias, but also for the faster ones, as I showed you. It was effective. And lastly, if you're going to get a shock, you wanted to make sure that that shock was going to become an effective shock, so use the high energy. And what we found out was when we used these strategies, using these prepare strategies, whether they were shocked for true VT-VF in red or true SVT in green, or you see these untreated VTs and such, the morbidity events were vastly reduced in comparison to the control group. So these strategies work to reduce the number of shocks, and which should improve the tolerance of the therapy as well. Now, confirming to this, and actually with a full randomized clinical trial and using strategies that are similar, the MADE-IT reduction in inappropriate therapy trial showed that there are two ways, at least two strategies, that are similarly effective in reducing inappropriate therapies. Now, of course, they kept track of appropriate therapies as well, but you can see that as a traditionally programmed device, there were many more inappropriate therapies in these patients. And whether you used the delayed therapy or the high-rate therapy limbs, you similarly reduced inappropriate therapies. Now, when we're talking about delayed therapy, we're kind of extremes. Delayed therapy meant waiting 60 seconds at 170 beats per minute, and then at 200 beats per minute, a relatively short time at 2.5 seconds, while high-rate therapy treated no arrhythmias less than 200 beats per minute, but, again, at a relatively short duration. So instead of combining the delay and the high rate, you did one or the other. Now, if you go back to my original statement that talked about appropriate versus inappropriate therapies, we see here that these therapies, high rate and delay, did not do same things for appropriate therapies versus inappropriate therapies. So if you look at shocks, the delayed therapy further reduced appropriate therapies, while, relatively speaking, inappropriate therapies were reduced further by the high-rate strategy. So we got going two different directions. Long duration, high rate, we got different impacts on appropriate and inappropriate therapies. If we look at how many people are programmed similar to these strategies, either the prepare strategies, which are put on this slide, where you see you see the number of patients during the various detection rates, and this should say greater than 188 beats per minute, and these are slower tachycardias. In orange would be how it was in prepare, and you see how a very small number of people are programmed to prolong detection or high rate, and even SVD discriminators and ATP for fast VT, and so we are not providing the kind of therapy that these studies are suggesting. And it makes a big difference. Detection thresholds, if your detection is 150, you're going to see more than double the number of tachycardias. And as you get closer to the very fast detection rates, you're going to reduce the number of therapies and the number of intervals to detect. You could actually reduce tachycardias if you have prolonged detection, and you actually get more if you have very fast detection rates. So what about survival? If you reduce these number of shocks, surprisingly, the survival was improved, both in prepare and also in MADE-IT RIT. As you can see, death was similarly reduced compared to conventional therapy, and there was no more syncope or morbidity seen as well. Now, if we look at these various approaches, we can see that by changing the detection rate from 188 to 150, and we see all these various detection algorithms, the prepare algorithm, the MADE-IT RIT algorithms are all similarly effective, while if you don't use them smartly, you end up going to not actually getting more tachycardias. say, looking at both MATED RIT and PREPARE and the other trials, that it is appropriate to have a monitor zone, and then from 180 to 190 beats per minute, have a VT zone with a target detection rate of 7 to 9 seconds with an ATP, and then a VF detection zone at a fairly fast rate so that you can get ATP below it. And using this kind of strategy, I think you can greatly reduce both appropriate and inappropriate therapies. Thank you.
Bruce, thank you very much for that presentation. That was very nicely done. You showed us what is done. You demonstrated from the literature what the potential impact can be from some of the maneuvers that are derived from the studies, and you give us some very practical suggestions. So having said that, Bruce, let me start off the discussion with you. One of the concerns, I think, is that physician groups and physicians have not actively utilized these programming changes such as the studies, and you suggest, in an aggressive manner. Patients come both as new implants and the larger number are in the clinic. So what strategies and what tactics would you suggest that physicians should utilize in approaching both of those groups of patients going forward?
Well, there are several stages to this. I mean, the most important thing is going forward, you need to have a strategy for programming these patients as you're putting the new devices in. And so you have to have a strategy, write it down, and implement it for all your patients going forward. Second of all, you have to, as the patients come in, make sure that you review their programming and make sure that you've made appropriate strategic choices in their programming, the patients as they come in to be followed up under your regular follow-ups. And lastly, you should be approaching these patients as with your remote monitoring. If they go into atrial fibrillation, that's a big multiplier of these events. You've got to make sure that they're programmed appropriately. If they have a shock, you make sure that they don't get more shocks, because you can do that by reducing their shock rate by implementing there. But if you do this and you follow the guidelines once a year to see everybody, you should within a year be able to get everybody within appropriate strategic programming.
So if physicians individually would do that, that would certainly get us there. What is your thought, Bruce, on how devices should be programmed out of the box at fault settings? And I realize there are FDA implications and regulations that impact on that, but what are your thoughts in that direction?
Well, first of all, both MATED RIT and PREPARE were primary prevention trials. But I can tell you that primary prevention, meaning that we have never seen arrhythmia before, you only have a perspective of strategically programming these patients. So you don't know what they're going to have. So you should use something like we've shown tonight. But I also can tell you from empiric that people that have had a VF arrest or syncope and inducible tachycardia behave exactly the same as those primary prevention patients. The only patients that you might consider differently are the people that have sustained monomorphic VT that you've seen before, in which case you have to lower the detection rates and in order to make sure that you detect those slower tachycardias.
Perfect. Mintu, a question for you. You presented, again, some very nice data on the healthcare utilization associated with ICD shocks. Given the emphasis in healthcare reform with improved quality and transparency and paying for performance and value-based purchasing, you mentioned bundling of payments. Many of these decisions don't just rest with the individual physician, but extend to the organizational structure. How would you suggest that organizations engage their physicians and their cardiovascular practices within that to bring these to a systemic process? Or do you think that that is something that should be happening?
Tom, I think that's a really great question. And I think the studies that Dr. Wilkoff illustrated are bringing us to a new era. We've had the NCDR, and we've looked at 30-day post-implant outcomes in terms of complications, and we've looked at the sort of quality of the implant. And now we're actually looking at what I would call the quality of programming. Putting it in correctly and making sure it's appropriately a single or a dual chamber device clearly is not enough, and the data supports that strongly. So as we're thinking of quality of programming, and it is clearly not part of any quality or performance measure right now, and I think that is important to emphasize for the audience. It might be in the future, but regardless, we know what needs to be done, as Dr. Wilcoff has outlined, for these patients. And I think, as you're saying, what would be important is an appropriate implementation structure on how this can be rolled out. So the nice thing is we are in an era where we now have large healthcare systems all over the country, and among the many protocols we have protocols for STEMI, we have protocols for many of the conditions we treat, heart failure discharge. I think healthcare organizations should think about ways that they can ensure that programming is evidence-based and the right thing for the patient. And of course, we're not looking at a one-size-fits-all for everyone, but we do know from the data that the parameters that we have now of extended detection at higher rates does improve survival and does lower utilization. We should be thinking about how to operationalize that.
And along those lines, I think one of the factors that is important is many of these clinics are run under physician supervision by technicians, extenders. How important do you think, Mintu, it is to get the educational message out to that group of individuals, since they are often our forefront or frontline role in a frontline role in this area?
Yeah, it's extremely important to emphasize that this is not just about the doctor in the room doing the implant or the doctor supervising a device clinic, but actually the techs, the nurse practitioner, the allied health providers that are on the front lines programming these devices. They need to be informed as well. And as we move forward with this, we may be in a situation where we can test out certain kinds of strategies. So, for example, could some sort of intervention or reminder be included on the programmer itself to say, hey, well, based on these data and the current program parameters, we would expect a shock rate of X, an appropriate shock rate and an inappropriate shock rate of Y, and if you consider modifying the settings, you may expect this kind of shock rate and potentially the survival benefit of this much. I mean, we have the data, we have the technology to do that. It remains to be seen if we can pull that off. But I think it's extremely important that all providers on the front line be aware of these important findings.
Bruce, both you and Mintu spoke during your presentations about the role of atrial leads and other SVT discriminators. I think it's very important to emphasize the things of which you spoke, the detection time characteristic changes and the more important frequent utilization of anti-tachycardia pacing is in addition to. Could you comment on that? Because I believe that, part of the reason perhaps why physicians have not utilized this may be that they're relying on, other data that, is not really, that is on which this is an additional component.
Yes, well, the keys are this. I think in somebody that you don't know what kind of tachycardia they're going to have, people who are primary prevention, there is no evidence that raising the detection rate will cause excess mortality. Matter of fact, it reduces mortality. And so you really do want to avoid detecting tachycardias that are less than 180 beats per minute. You can monitor them, but you want to raise that detection rate to at least 180, maybe 188. Some of the data would suggest beats per minute. I think that raising it all the way to 200 as a made at RIT is probably not the best balance here. And so then once you detect, you want to treat them all at least once with ATP. Our data would show that 75% of the time the first ATP will work, maybe another 10 or 12% the second ATP works. It's very rare for need more than two ATPs, and actually one ATP is more than adequate. So the ATP, a faster detection rate, prolonged detection time allows you to get rid of a lot of atrial fibrillation and allows you to get rid of the non-sustained ventricular tachycardia, like I said in the first slide. So those are the hallmarks of what you want to be doing. And we, in the past, have rushed to diagnosis because we thought our patients were going to die if we didn't treat them quickly. The answer is our patients are going to die if we don't wait to make sure that it needed to be treated. They're going to live longer and feel better if you delay until you're absolutely sure and then treat them aggressively.
Well, thank you again very much. I want to thank both of you, Dr. Wilkoff and Dr. Tarakia, for your excellent presentations, which really have brought up this issue that is quite important and probably under-recognized by the medical community, and for your engaging discussion as well as your practical recommendations on how to approach patients who have implanted devices. I thank you both very much and appreciate the input.
Today's program is copyrighted in 2013 by the American College of Cardiology and the Heart Rhythm Society with all rights reserved. This concludes the program. Thank you.